Hey, Gestalt Education Nation. New sponsor alert. Today, we're excited to announce Dynamic Disc Designs and Jerome Fryer. We have an awesome discount code for you. Just use the code Gestalt to get a little bit of money off on the Dynamic Disc Designs. They're the most realistic anatomical discs that we've ever seen. If you caught our episode with Dr. Stuart McGill, you saw an entire shelf full of them. Everything from cavitation instruction to disc dysfunction to SI joint dysfunction, all sorts of amazing
joint
stuff.
movement,
Yes,
vertebral movement.
Absolutely. So go to Dynamic Disc Designs, use the code Gestalt. As always, you can use the code Gestalt on Core 360 belt to get a little discount on the belts there. We love to use that for biofeedback for teaching respiration, intra-abdominal pressure, and how the abdominal wall should be working during function. And then the last one, use the code Gestalt Education 10. Those will all be in the description in the podcast. Gestalt Education 10 at humanlocomotion.com to get off some money off of all of his awesome gadgets and tools and rehab materials. What's your favorite, Brett?
He's got a trunk full, but I think, integrating the Toe Pro, and I think, has been a game changer for us here at the office. So I think that would be my pick.
Beautiful. All right, guys, don't forget, use the code Gestalt, Gestalt Education 10. Visit the show notes and you'll be hooked up. Thanks. Enjoy the episode. All right, everyone. Welcome to another episode of the Gestalt Education Show. Today, we are back in Colorado Springs at the Active Release Tech ART headquarters here with the one and only Mike Leahy. So it's been a year to almost the day that
That's
we were
hard
here.
to believe.
I know.
Really?
It is crazy.
A year already?
Yeah, it's crazy. So today, we're kind of changing gears. So the last time we spoke, we talked about everything ART, the history of it, how you conceptually came up with it, the technique itself, all those types of things. Today, we're gonna kind of pin you down to a little bit more of a direct question or a direct topic. We're going to talk about nerves, right? We're going to talk about muscles play with nerves. We're going to maybe introduce a little fascia with nerves. We're going to talk about all sorts of neurology that involves that. And so you've had a long nerve course in the ART curriculum for quite a while now, correct?
Correct.
Yeah. And so what kind of started that, or did that start out of a need? You saw that there was a need to start teaching that, or kind of what started your fascination with those types of things?
Well, I look at it like it goes, it starts from basic chiropractic philosophy. If you put 1,000 chiropractors in a room and try to get everyone to agree on one thing, pretty hard. Yeah. But that was actually done in California 20 years ago. And the only one thing that everyone could buy into was the subluxation causes interference with that nerve transmission. That was it. And that the manipulation was the fix for that.
Sure.
So if you look at how many places does a subluxation of a vertebra affect a nerve in the body, how many of those sites are there? Well, that's a kind of a trick question because it depends on how you count the nerves of the sacrum. But let's say there's 32 on each side for nerve roots that can be affected by a subluxation. So there's 64. How many places can you have interference with a nerve function outside the spine? At least 100 on each side.
At least.
At least.
Yeah. Oh, man.
Well, the problem is, like the ulnar nerve, for example, we know it gets trapped at the elbow, near the flexor carpi ulnaris, and then it can be, affected in the tunnel of Guyon. So there's two places, but it can be trapped any place in between or the entire area. So you can't really count.
Sure.
But that's a lot of places. So I happen to be a chiropractor. If I believe that I need to address problems with nerves, I can't just address the spine. I'm not even getting half of it.
Right.
So that developed into, okay, where do nerves get entrapped? And I'd say entrapped, that's there's either too much tension or too much pressure on a nerve. Those are the two major things. And that's caused by pressure from surrounding tissues, or the nerve is stuck to a tissue. Call it scarring. It's not always scarring, but let's call it that. And so it can't slide. And so when you move where the nerve is supposed to slide, it doesn't slide, then there's a real common entrapment site there.
And what are some of the key things you use from a diagnostic palpatory standpoint? Like what is What allows you to be able to feel this?
Well, that's the next question. How do you find these things?
Yeah.
Okay. Well, fortunately, you can find them with your hands better than you can with electrodiagnostics or an MRI or a CAT scan. Once in a while they'll show up on that with electrophysiology. That's, there's as many false positives as there are false negatives. So it's kind of a wash. Gives you an idea, but it's a lot easier with your hands. And the trick is to use the nerve. Let's say the median nerve. So it goes from the end of two fingers in your thumb all the way into the, it changes its name in the shoulder area, but it goes all the way into the spine. Okay, those cells go all the way into the spine. So where can it be entrapped and how do you find it? It used to be thought that the most common one was the carpal tunnel. It's almost never the carpal tunnel.
That's right.
So we pretty much never do carpal tunnel surgery anymore because it's usually not there. And even if it is there, it can be fixed manually without surgery anyway.
Right.
So, but if I take my fingers and the thumb and extend those, I'm pulling on the nerve, right? If it was going to be stuck in the carpal tunnel, if I put my finger or my thumb at the distal edge of the carpal tunnel, and then extend the thumb and the fingers as far as they'll go. If the nerve is stuck, I'll feel that tissue tighten up because the nerve's going to want to pull whatever it's stuck to.
Right.
And you can feel that. We say if you want to do that find all these spots on your own, you can. It's going to take you 15 years because you don't know what they feel like. But if somebody puts your thumb on it and then, finds an entrapment, puts your thumb on it and then pulls it and say, okay, what your thumb on right now, you can feel that little tug, move your thumb sideways back and forth. Okay. Feel the nerve, that little string in there. Once you find it once they actually demonstrate it to you, then it's easy.
Sure.
You'll always find it. So, what we've done is we've tried to quantify all these sites of entrapment and the palpation method of finding it by locking tissues in place and moving the nerve to a place where it's actually easy to feel. And you can find all these entrapment sites and you can feel whether it's stuck or sliding. It's aided by symptoms.
Sure.
Because if you find the place that it's stuck, and you pull on it, more than likely you're going to duplicate what the patient says is the problem. It's not a perfect indicator, but it is an indicator. Sure. So the whole secret is quantifying it, but teaching it in a way to where it jumpstarts the learning process, and it makes it useful to you very quickly. That makes sense?
Oh, yeah. What ended up making you put that in the curriculum originally? I remember when I went through the coursework, you had all the different muscle releases, and then at the end was the nerve entrapment. So was there a moment in your career when you were like, okay, we need to start thinking about this? What was that?
That's probably a fault of mine. When I did the
be in the beginning.
When I did the first ART course, I used a beta version of the first video editing commercially system available. It was just a big circuit board, and I hooked tape recorders up to it, and then we filmed it in the front office of our clinic, and we filmed 27 protocols that covered the entire body. And I thought that was enough. And you should be able to take those 27 and then do little modifications here and there and then cover the entire body. Because I guess that's the way I thought. That was not accurate. You had to define it a whole lot better to make it usable. So it's just been the process. Defined all the muscles, ligaments, tendons, and joints first, and nerves kind of along with that. And then I realized, we haven't done enough on the nerves. So then we did an actual nerve course, and we called it long track nerves, the 5 major long nerves, those tracks, and where they ran into problems. And we made that a course. So that's how that happened.
What are the most common nerve entrapment sites that you find? Obviously, you were hinting around the pronator teres earlier. What are the other big ones that people are missing out in practice, do you think?
The biggest one is sciatica. I hate to think of how many people when I first started practice that I thought they had a disc problem because you could see bulge on the
MRI,
CAT scan or the MRI. I mean, MRI was just starting then. That kind of dates me. But you could see what might be a problem there and put that together with the symptoms. Oh, it's a disc problem.
Yeah.
And probably 3/4 of those were not disc problems.
Right.
So the most common is actually a nerve root stuck in the foramen, one of the sciatic nerve roots. And the second most common is the sciatic nerve stuck in the hip. And it's actually, it does get stuck and trapped by the piriformis, but that's not the majority of them. The majority of them in the hip are actually the superior gemellus and obturator and inferior gemellus. They get stuck to those, although they're usually blamed on the piriformis.
Sure. When the nerve root gets stuck, are those old herniations and cases like that have kind of progressed into that, or what do you think the trajectory is?
Not usually.
No.
Not usually. It's
so
a
no
slow
disc pathology at all, just the nerves.
There is obviously disc pathology sometimes.
Right.
Yeah, and it will cause a great problem.
Right.
But far more common is the nerve root stuck in the foramen.
Right.
And if you look at it as how could I irritate that nerve? Well, I could yank on it real hard. I could run. A sprinter would take really big steps. You know, that nerve has to go about 1.5 centimeters through the foramen with that full range of motion.
Right.
Well, what if I'm using it really hard and I cause some inflammation in there just from the movement? And then I do it again and I do it again, and so it's always inflamed. Sure. It'll cause that inflammation can cause scarring, and the scarring will start to bind the tissues, and that will make the problem worse, which causes more inflammation, which causes more scarring, and you get into what we call the cumulative injury cycle.
Sure.
And you can solve the inflammation problem by relaxing the tissues, or using steroid, injecting it. If you get in the right place, it'll take the inflammation away. Oh, that's all gone. Mm-hmm. But in a week, it's back again because you didn't break. Literally, we say release. Release is a better word than break. You break the connection between the nerve and the foramen itself.
Sure.
So, you know, the sciatic nerve also can actually be stuck to the pelvis, the bone, in the little arch where it comes out and then goes in between the muscles. It doesn't happen that often, but that's similar to the nerve root stuck in the foramen. So then the secret again is, well, how do you palpate that?
Yeah, because I would imagine that's pretty deep at that point.
Well, the sciatic nerve at the foramen is actually remarkably easy, and it's easily learned because it doesn't depend much on palpation. It's very difficult for me to put my thumb in the foramen and feel what the nerve's doing.
Right.
But what I can do is lay the patient on the side, keep the knee straight, and flex the hip. When I flex the hip, the tension on the hamstrings increases in a linear curve. So the farther I go, the tighter it gets. And it's proportional. It's a steady increase. If the nerve root is stuck in the foramen, you'll get tighter, and all of a sudden that rate of tightness just jumps up, and all of a sudden it locks up those hamstrings. That's not the muscle.
Right.
That's the sciatic nerve that's stuck in the foramen. So now I know where it is. And then what I'll use the entire spinal cord and the entire sciatic nerve and move them so that nerve root goes in towards the spinal cord and out to spinal cord using that entire complex back and forth, and you can free up the nerve like that.
Sounds a little bit like neural mobilization there.
Yeah, it does. Yeah.
Well, there's different names, nerve gliding, neuromobilization.
Sure,
The problem with the way that is usually approached is you stretch the entire nerve and then you move one thing at the end.
Yeah,
You're not getting a lot of relative motion there.
Right.
It's a good diagnostic process, but it's not going to fix things very well. So you have to be a little more clever than that. and use that entire nerve complex to move everything one way and then the other. And that's why we call it long tract nerve release.
I'm sure.
Because you're moving the whole tract.
Yeah.
And so, in the frame, it's one thing. I don't have to have a contact, so it's easier. But let's say it's stuck in the hamstrings, right where you have that split in the medial and lateral hamstrings. I can hold the hamstrings proximal and, arch the back, take the pressure off the spinal cord and the sciatic nerve above the hamstrings, extend the hip, hold the hamstrings proximal, and then extend the knee, dorsiflex the ankle, extend the toes, pull the nerve distally, and hold the muscles proximally. And then reverse my tension and do it the other way. That way you get the most relative motion possible. And I'm pushing the tissue the opposite way the nerve's moving until it releases.
Beautiful. I love it.
There's been a lot of debate of whether there's actually a double crush syndrome. Are you familiar with that term? Like where you potentially have...
We call that a whole nerve syndrome.
Okay.
Because I think double crush is that's a useful term, but I don't think it's actually double crush.
Right. That's what a lot of people say about it. Yeah.
That's one of the problems why NCVs and electrodiagnostics there's such a big false positive negative, because let's say the nerve actually is stuck in the carpal tunnel. I put pressure on it. So I should get a positive test across in conduction velocity, through that area, right? Well, the problem is that whole nerve is affected by that. So that conduction velocity can change along the entire course of the nerve. Because the whole nerve is affected.
Yeah, exactly.
So then you get confusing and mixed results on where the problem is. That's when I think you have to rely on your palpation skills.
Physical.
To isolate where the entrapment is.
Sure.
And that's how we found that it's almost never in the carpal tunnel.
Right.
And that's probably why carpal tunnel surgery has such dismal results.
Right. What about, are you using... What other testing besides palpation are you using in those patients? Patient comes in with numbness, tingling in the hand. What are some of the other things that you're utilizing? Are you relying majority on palpation and symptoms in general, just subjective symptoms, or are there other things you're
symptoms
using?
In general will give you a start.
Sure.
It's a good start.
Mm-hmm.
The nerve entrapment is often at the most, or near the most proximal symptom site, but not always.
Sure.
Because you can trap the sciatic nerve, say, at the foramen, and your foot goes numb first.
Fair.
So it's not always true.
Right.
But that's a starting point. Symptoms certainly is. And also, if you know by symptoms that it is the sciatic nerve, that's a pretty good starting point too.
That's very good. Yeah.
But what we emphasize to people is that it's only a starting point. So we use a process called the diagnostic algorithm. Show me the position or motion that causes the problem. Not pain. I don't want to limit it to pain.
Right.
Show me. Demonstrate to me where the problem is. They're going to know. Okay, that becomes my test motion. So in a case of sciatica, a person leans over and gets sciatica down the leg. Okay, well, I kind of know it's sciatica, but I'm not going to jump on the disc right away.
Sure.
Because there's that, 3 feet or 2.5 feet worth of sites that it could be. Mm-hmm. So what I'll do is that's my starting point from what they say is as a symptom, but I've also got a motion or a position. So I'll use that as a test. So I'm going to have them repeat that motion, and I'm going to start to palpate from the distal end of the sciatic nerve and palpate the entire course until their symptom matches what I'm feeling with my hand.
Right.
And almost always, if you find the right spot, that will tug on your fingers just before they say, there it is.
Right.
And if that happens, and if you're stubborn enough to keep looking and not fall for the most obvious place, and you find the source, then you fix that first. And then usually the other symptoms go away.
Sure.
And that's confirmation that you found the source. If the other symptoms don't go away, then it's either there's some other spot too,
Right.
or I found a spot and I'm not good enough to fix it, at least in one try.
Sure.
And is it as simple as you do the manual treatment and we do a couple treatments, everything's fine? Or is there any kind of home care that with neuromobilization or anything like that they would go home with? Or basically we've taken care of the problem manually and then there would be no home component to that?
Well, in particular with nerves, when you have, let's say nerve root is stuck in the hip, if you try to stretch that and mobilize it yourself, really all you're going to do is irritate it.
Yeah, that's true.
It doesn't progress very well. I can't see it. That's not 100% of the cases, but
a
it's
lot
90.
of time. Yeah, no, you're right.
And so, but after you fix it, then the question is, will exercise or mobilization help? Well, my first thought is, if you truly release the nerve, it's released. It's not going to come back right away. But if you do the same thing that you did for 6 years and that caused it to happen, you can make it happen again.
Yeah.
So then I think it's important to show the person what you think the cause was and how to avoid that. And it's not usually, I'm a runner, okay, don't run anymore. It's usually avoid. It sounds really trite to say that, but if it hurts, don't do that.
Right.
More accurately, if it hurts and it gets worse as you're doing it, then you just went too far.
Sure.
Or too hard. I think that's a little more accurate. But that's not to say that exercise or mobilization is a bad thing. It's a great thing. And I think in terms of neuromobilization, if you fix the entrapment, if once in a while you keep it moving, it's a lot harder for it to get stuck. Mm-hmm. Because when it starts to form a little scar tissue, say from inflammation, you're doing the same things again, and it gets inflamed, and it's trying to form that scar tissue. If you keep moving the nerve through the pronator teres, it's not going to get stuck.
Sure. Because
you keep breaking it loose when there's almost no excessive tension on it.
Right.
In your experience, if you have I don't know if you use maybe primary or secondary, let's say you have multiple entrapment sites. If you're finding the key link, do you find that the other entrapments are going away, or do you find yourself having to work on maybe two different sites that it's being entrapped? Or is there usually just like one primary and then you're good to go?
It could be either one. Okay. And there's two parts to that, really. Okay, using double crush, which I call a whole nerve, whole nerve situation. I'm stuck at the pronator teres, the median nerve at the pronator teres. But it's very common for it to be stuck in the shoulder, right in what we call the corticopectoral tunnel. It can be stuck to the subscapularis, the pec minor, even the corcoid process itself. It can be stuck to the bone. That medial tract that eventually forms the median nerve. So I fix it here. Patient says it's completely gone. Okay, but I have to trace the nerve from the fingers to the spine, or I really fall vulnerable to it coming back again.
Right.
So you have to find all those other spots that it could be trapped. And that's hard for us to do, because when we fix that spot and the patient jumps up, it's completely gone, you're a miracle worker. It's really easy to stop there and take credit for it.
Right.
Yeah.
It really is.
Sorry to interrupt your episode, guys. I have to tell you about an important date to write down in your calendar, November 3rd through the 5th, the first annual Neurodynamics World Congress coming to you at Parker University in Dallas, Texas, November 3rd through the 5th. This is an amazing opportunity to see a true Gestalt weekend, meaning integration of multiple different people, multiple different techniques of the likes of Michael Leahy, Antonio Stecco, Brent Winchester talking about DNS, Annie O'Connor talking about pain classification mechanisms, David Seaming talking about the internal chemistry, Jeff Bove talking about the research around nerves, and of course Michael Shacklock talking about neurodynamics. This weekend at Parker University, November 3rd through the 5th is your opportunity to see not only lectures, but hands-on demonstrations and panel discussions at the end of every day to combine this all together to show how each of these different techniques is influencing the nervous system. This is an amazing opportunity to see all these people in one stage and one opportunity to have some fun with us in Gestalt education. So thanks for taking the time to listen to this episode, and we can't wait to see you at Park University. It's November 3rd through the 5th. Registration open at gestaltedu.com/courses. See you there.
That's exactly right. Well, what do you think about, like, in baseball right now with pitching? We have an epidemic problem with thoracic outlet syndrome. So we're doing very, very invasive surgeries for that. Do you think
we never do surgery for thoracic outlet anymore?
Yeah, elaborate. So tell me what
especially like the vascular component is the main reason why we're getting to that point too.
Yeah. Mm-hmm. Yeah, I had a surgeon get really mad at me for even suggesting that there's something other that you can do for thoracic outlet.
Right.
In my mind, the most common cause of that is that the neurovascular components get stuck in between the anterior and the middle scalene. Very easy to find, very easy to fix. You relax the nerve on the proximal side, you hold the one or both of those muscles proximally towards the spine, and you abduct, extend, externally rotate, extend the elbow because it's usually the median tract is the worst, not always, but so you do all three tracts, the median, radial, and ulnar tract, but you also have to pay attention to the vascular components as well, because it can be stuck there as well. But that's not the only spot. There's several, I'd say, areas between the scalenes and the clavicle, subclavius, pect minor, and then that corticopectoral, tunnel.
Sure.
It could be stuck anywhere in there, and just to the roof of the axilla. Very common for it to be stuck in there. Mm-hmm. I don't know the statistics because I haven't tried to document those, but I'll bet those neurovascular structures being stuck in the axilla itself on muscle or just the roof of the axilla and the coracoid process is maybe more common than just the scalenes. But I'd say they go together.
Sure.
So if one's there, the other's probably going to be there.
Fair.
So if, say, you had a quarterback that had several surgeries in the neck and had a thoracic outlet syndrome, and he had almost no strength in the triceps and was using every other muscle to throw the ball and doing it pretty well. And then you found those 5 nerve entrapments between the neck and halfway down the arm and fixed that and gained full strength. That would be a proof of that concept. Mm-hmm.
That quarterback just happened to
is someone coming out of retirement?
Blue and orange there? Or, I don't know.
So
no, there's not only one.
Sure.
There's not only one quarterback. And
we say that, the master acupuncturist only needs one needle. So like when we're talking about entrapment sites, is it you've done this so long, Mike, that where in that example, exactly where you need to be? Or, when you got a seminar going on here next door, do you teach them to just go ahead and release all the entrapment sites just to be safe as you're learning, as you get better? Or what does that all look like as far as, your career path? And
the more experienced we are, we've all seen patients with a shoulder impingement syndrome. Okay. It's the subscapularis. Well, it usually is.
Yeah. Start there.
But the problem is our experience makes us think automatically that we know and that's, if you think about it, we all learn to diagnose by symptoms.
Right.
Memorize 8 million symptoms, put these 4 together, and you have shoulder impingement. It works pretty well, but only if you know all 8 million symptoms, and you can take those 4 out of that. But even that, you can be wrong. And I am as guilty at that as anybody. So,
I think too, when you've had success, you've seen 3 times when subscapularis was the miracle treatment, you see the 4th and you automatically are going there.
Oh yeah. I fall victim to that
all
the time. Yeah. For years, we said subscapularis, pronator teres, and psoas are the 3 miracle muscles.
Yeah.
You could make an entire practice out of any one of those. But there's a lot of people that you wouldn't fix. You'd make them feel better,
Right.
but you wouldn't fix.
Sure.
So go through the process, do the diagnostic algorithm, and keep doing it. Step one, show me the position or motion. Step two, I palpate it, or step one, palpate that, and I feel for the first aberrant thing that happens. Okay, not the most obvious thing.
Sure.
More than half the time, it's not the most obvious, but that's what we think we know what it is.
Right.
So what happens is we're looking for that subscapularis because we think that's what it is. And if we find it, okay, I'm done. I'll go fix that. And then I've done a miracle. It's hard not to, but don't fall into that trap. Find the first aberrant thing, and it may not be the most obvious thing. And then when you isolate it and figure out what structure that is that you found, and then fix it, which is the easiest part, then go back to step one and do it again, because they'll move a little farther and something else will show up. And you keep doing that, step 1, 2, 3, 1, 2, 3, until the patient says nothing's wrong and you say nothing's wrong. Then you're done.
Sure.
But you have to work hard to do that.
Right.
Right.
Yeah, you got to want to get better, and you got to grind it out, and you got to.
It's frustrating because it depends so much on your palpation skills. And that's what we spend all our time doing now, is jump-starting people on palpation skills.
Mm-hmm. Yeah.
And so it's frustrating because you're going to spend a lot of time looking for these spots, and they're subtle. They're hard to find most of the time.
Sure.
So it's hard.
And how often do you think out in the wild that people are getting treatment, not necessarily an ART, but they're responding to the treatment, let's just say greater occipital nerve entrapment.
Yeah.
So they're doing something and they just thought that it was their treatment that was helping it, but actually it ended up being this nerve entrapment. Do you think that's happening quite often throughout the body?
Obviously, yes.
Yeah.
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 Yeah. I think that's the difference between.
I guess do you need, how important is specific treatment for greater occipital nerve entrapment versus what everyone else is doing?
It's a scale.
Yeah.
The more specific and accurate
Right.
that you can be, the better your outcomes will be. And we're all on that scale someplace.
Right.
I would like it if all of us kept moving up that scale, more specific, more accurate, and that road never ends.
Right.
There's no time where you can say, okay, I have that. I know that. I'm good at that. You have to keep learning it.
Sure.
We talked a little bit about this on the first podcast, but not the treatment of active release. But what are some tips that you would give somebody on just getting better solely at palpation? Besides experience, of course, that's the obvious one. But like, what is it that you actually need to get better at? You got to know anatomy, of course.
Well, I'd say, find somebody who's better than you are and have him show you those problem sites.
Find a good mentor, yeah.
It's hard to do because, we're seeing people that come in. You may not see XYZ
right
every day.
Oh, that's true.
So it's really hard to do. But that would be the most advantageous, is actually to palpate on a patient that already has something and find it. Now you know what it feels like. You'll never miss it.
Yeah.
Now, the next best thing is whatever technique you like, go to the class, and in the class, there's all kind of things in the people that are in the class that you can find.
Right.
There's always things that you can find. When something is found, you should palpate that and see what it feels like. Because once you find it once, you can always find it. Mm. The problem is you need to have somebody actually point it out to you and you feel it. And then the learning curve is so much faster.
It's beautiful.
What about the parts of the body where we actually don't have nerve entrapment? We actually have too much movement, like the ulnar nerve on the medial side of the elbow. So what do you feel like they're entrapped proximally or distally, and potentially that's what's creating the hypermobility? Or
that problem occurs in fascia more than any other tissue. If you think about it, how do we work fascia? How have you been taught to work fascia?
Friction.
It's too tight and you loosen it up, right?
Sure. Yeah.
Is it always too tight?
It's a good question.
Could it be too loose?
It's very possible.
How do you know?
I'm going to guess you're going to tell us right now.
Well, and I think everyone's got their own genetic, soft tissue matrix too. Like, I mean, it's almost like a genetic
sliding scale
predisposition of we've all palpated people that, have tight fascia, and then we have ones that kind of have loose fascia.
Yes, there is that nebulous thing. When it's really too tight, you can tell it's too tight.
Right.
But if you look at on the nervous system side, spindle cells are all over the place in the fascia. And myofibroblasts are all over the place in fascia. A lot more than when I went to school. Myofibroblasts are, what a cute little cell, Yeah. So what? But they actually contract like muscle cells, albeit slower. So what we need is a system to know when tension is affecting function. It's stability and control is what it is. I'm a geek. I'm an engineer. I look at it as stability and control, single loop negative feedback control systems.
Yeah.
When you start to affect that negative feedback control system aberrantly, then you have a problem in the tissue. And in that case, it's usually something is too tight. Not always, but usually. Mm-hmm. So then you have to have a way to find where it's too tight and where it's normal.
Right.
And then only address the too tight spot. Once I figured that out, low back pain in particular, somewhere around half the low back pain patients I see, the problem's not in the low back. It's in the fascia someplace. And it's along these chains, lines or chains, people call them different things. And you have to be able to sequentially isolate each segment in the chain and find out where the source of the problem is. And then what you do is you treat the fascia between the last problem spot in the chain continuously through the problem area, the symptomatic area. And that could be either side. It could be proximal or distal side of the chains.
And how is active release teaching fascial? We'll start with the palpation, and then we'll get into treatment.
We're not yet.
Oh,
I'm in the process of writing it. It's so tedious, I don't do well with that tedious part.
Yeah, I get it.
I do better if I could just talk through it and have somebody else write it.
Absolutely.
So I actually brought 2 other people that are going to help me write it.
Okay.
So,
beautiful. Well, and I mean, that kind of takes us into our, one hidden agenda behind coming here to talk to you about the nerves is we have a big nerve conference basically in November. So Antonio Stecco, I know you talked to us beforehand. Carla Stecco's book was a big influence on you. Huge influence when you're discussing this stuff. And we're going to talk about Michael Shacklock, who literally wrote the book on neuromobilization and things like that. You yourself are going to talk on similar topics. Mm-hmm. I can't wait for the topics or the cross conversation on fascia. I'm sure that there'll be some sparks of inspiration on both sides of the camps there. So, where did that fascia start? I know you kind of got a little bit of more of a spark on it this time than the last time we saw you.
Yeah. For example, there's let's take low back pain. There are several areas of the fascia that can cause problems that go into the low back. And we know if you look at the muscles, mm-hmm. They're the functional chains, we know what those are. But the fascial chains, most people don't understand them completely. They know there's a line or a chain, mm-hmm. and they're all connected. But too many people say, it's all connected. Everything's connected to everything. And so, but what happens? And that's where the nervous system comes into play. The fascia lata, for example. What if the IT band is mostly aponeurotic fascia, where a lot of the fibers are longitudinally oriented. And so its chief communication is transmitting force. But that system transmits force several times faster than the nervous system can. But the fascia lata, the bulk of the fascia lata around the thigh isn't wired like that. So its primary function is sensing tension and position. And that signal goes to the spinal cord, internuncial neurolateral spinal thalamic tract up to the brain, and it becomes the chief part feedback loop controlling what we do to the muscle. But that's not oriented the same way the muscle is. Muscle crosses a joint and attaches to a bone on each side of the joint, one or more joints across. Mm-hmm. This fascia is connected all the way through.
Sure.
So it's different. So you can't approach it the same way as we do muscles. So the segments that we look at a time are generally across one joint. But in the area of the spine, for example, the psoas and the iliacus fascia coalesces and then extends past where it attaches on the femur and goes and surrounds the rectus femoris. So the rectus femoris and the psoas, although they're not connected, the muscles aren't. The fascia is.
Right.
So they work in concert with one another.
Well, do you think then, part of the amazing results with active release over all these years has been that you've inadvertently also been working with fascia without even, maybe you knew it, but didn't really talk about it as much?
Yeah, we certainly didn't talk about it as much, but although we told you, you're probably working fascia more than what we consider the contractile fibers of a muscle.
Yeah.
You're working fascia more than those fibers.
Right.
And so what we always said is when you find aberrant tension, you need to follow that line of tension wherever it goes. And it doesn't always go where the muscle goes. So fix the muscle. That's the easy part. Mm-hmm. But then follow the line of tension. And you're following fascia when you do that. But that has always been the approach. Start with the muscle, fix the muscle, and then follow the fascia.
In fascial manipulation, according to Stecco, the patient is very passive. Do you foresee in active release that the patient would be doing active motions during?
Absolutely.
Yeah.
Absolutely. It's easier to do with the patient passive. But again, we start, lumping everything into it's stiff this way, it's too tight. I'm going to treat it passively and make everything looser.
Right.
More often than not, you're probably going to be correct.
Yeah.
But not always.
Right.
And I think when we do that, we don't really understand what's going on.
Right.
Another thing that happens with fascia, let's say I can grab just proximal to the patella and I can stretch on that tissue really hard. And I'm going to affect the Golgi tendon organs, aren't I? And if I push that fascia toward the patella just once with my hand, and then test the strength of the quadriceps, they're stronger. If I pull that fascia proximal off the patella, quadriceps get weaker instantly. Doesn't last.
Right.
So, and then another way you can do it, if I put my thumb right where the Golgi tendon organ is, and I just mash it, I can basically anesthetize the Golgi tendon organ. And it's really convincing to an athlete when you test the quadriceps strength and, mash the Golgi tendon as much as they can take and then test the strength again, it's stronger. And it's going to be stronger for a period of time.
How long you think?
It depends on so many things. I don't have a good answer to that, to be honest.
Right.
But I would venture to say it's not permanent change.
Right.
Unless you injure the Golgi tendon.
Right.
Then maybe it could be a permanent change.
Because you have a lot of experience working with people with muscle activation technique, correct?
Yeah.
Yeah.
Uh-huh.
So, it's a good marriage, I'm assuming.
It's really good.
Yeah. Yeah.
And I think especially on a diagnostic routine, that's really good.
Yeah.
Because it can tell you that there's a problem there.
Yeah.
And, but what if you figured out exactly what that whole chain of fascia was doing and actually fixed that? Change the myofibroblasts in the fascia, which can be a relatively permanent change.
Right.
And then that takes the pressure off the Golgi tendon. Now you have a more permanent change.
Do you think the treatment time for fascia is going to be different than muscles? So, like, I mean, if we do a couple, active release passes, I mean, that can be done in a pretty short period of time when you're,
The more the problem is in contractile tissues, the faster there will respond, and the less time you have to treat it. But the more it's, and I shouldn't say contractile tissues, muscle contractile tissues. Right. The more it gets into myofibroblasts and cells that are less contractile than that,
right,
then you're going to have to spend more time.
Yeah.
But I think just from experience, not from quantitative analysis, but from experience, when I'm working with fascia, it usually takes 10 to 30 seconds of work to get those to change. And sometimes it's 2 minutes, but it's not a half an hour, and it's not 2 seconds. So yes, it's slower when you work fascia. Usually
in the Stecco way of thinking, that you might be using an elbow or you might be using a knuckle. Are you still using your hand, or what do you?
Well, there's a trade-off there. When you use your elbow, you're going to irritate the tissues pretty well because the pounds per square inch is going to go way up. Mm-hmm. So, but let's say I have to exert a 15-pound tension on the myofibroblast and hold it for 20 seconds to get it to let it go, just as an example. Okay, if I use my elbow in it, it's easier to maintain that pressure. It's easier for the practitioner. Mm-hmm. But the problem is most of the force is going to be in compression rather than tension. And compression is not what fixes it. The holding of tension is what fixes it. So there's the trade-off. You want the pounds per square inch to be low, but you want the pounds to be high, which means a broad contact, which uses your hands. There's another couple reasons for that. One is the patient, which is kind of important. The lower the PSI and the higher the pressure, the more comfortable it is. So if they're scarring, for example, in the fascia, I can go 4 times as hard doing it that way and break the fascia than I can with my elbow. Mm-hmm. See, because first of all, the patient won't let me because it's too painful to exert that much force, tension on the tissues because it's too much compression. But the other thing is the tissue has a maximum as well. There's a tissue sensitivity. And you can generally feel that the tissue is starting to react. In a muscle, per se, once you add too much compression in particular, but it can go along with tension, but especially if you have too much compression, you'll just barely start to get a little quiver in the muscle. You just went too hard. And you're actually going to make them worse rather than better. And that happens all the time at the elbow. You can pull the tissues loose, but you actually make the problem worse because you're causing inflammation.
Right.
Which will then cause scarring. And
their group, they use the term densification. That's the term that they like. Do you like that term or not?
For talking about fascia?
Because they really don't separate, we've actually had them on our podcast and we asked them specifically, I mean, are you delineated between a trigger point, between adhesion, between a densification? And basically the answer was densification is densification.
Densification is the problem?
Right.
Yeah. Well, I don't think that's wrong.
Right.
Because if I have a tissue, fascia or muscle, and it contracts, you could feel that the tissue is more dense. It isn't always. It could be harder, which some people palpate as density. So the densification isn't always an accurate term, but it is, I think, appropriate.
Right. Broad-based and yeah.
Sure. Yeah.
I think that what we were trying to get at, and you said this earlier, so I kind of know what the answer is, but I want you to elaborate on it. What's the difference between fascial restriction and muscle restriction?
A muscle, if it has if the modulus of elasticity goes down, it doesn't stretch as easily. And it also doesn't stretch as easily quickly, which is the more important part. You can get it to stretch, but if you try to do it fast, it'll tear because the elasticity went down. So for an athlete, that's absolutely the most critical part. It's a sprinter. Their worst fear is a hamstring pull, but it's the modulus of elasticity in that really does that. So, and you can apply that to fascia as well. It's, elasticity. If the myofibroblasts are all contracted, it's less elastic. If you can tease them into relaxing, then it's more elastic. And so it'll stretch easier.
Right.
It'll still signal the spindle cells.
Right.
But it doesn't restrict motion. Am I answering your question?
Oh, you are.
Yeah.
Which leads me to the next question. You work with so many athletes, Mike. Do you see this, like the future of this, almost like a wellness chiropractic checkup to where, these athletes don't have any pain, but they, there's so many different things and components you could be doing to work on their athleticism. I mean,
Absolutely.
Yeah.
Yeah. That's,
do you see that getting done?
When I'm working with athletes, I look at it as, okay, I'm solving an injury.
Right.
Is the most common one. What I like to do the most, though, is get into performance. And some people think, well, you can't change performance. Well, of course you can. If you have an athlete that has the talent and his quadriceps don't contract through a mechanical restriction, and you take the mechanical restriction, you just change performance.
Right.
You didn't change his talent. So you can't really take credit for what he does. He's the one doing it.
Right.
He or she. And so, but you can change you can take the stumbling blocks out of the way.
Right.
And in that change performance. That's what I like the most.
Yeah.
And the easiest place to see that is in a sport that takes a 100% effort. If you take a marathoner or an Ironman triathlete, there's so many factors in play. I can fix all these things. I don't know if that's going to make him faster.
Right.
What if it's hotter that day?
Yeah, right.
He won't be as fast.
And that takes some pressure off you, though. I mean, all you can do is work on what you find that.
Yeah, but the reason I'm being kind of long-winded about this is because generally what happens is people want to take credit for the athlete's performance.
Oh, yeah.
I work with
then you got to take credit for it when it doesn't go.
Absolutely.
Yeah.
We've all been there.
And there are so many factors out of our control.
Oh,
when they do
God,
worse,
yeah.
you still have to take
you
credit.
still got to eat
if you
that.
take credit for the first one. So we're not changing his talent. But if I take the stumbling blocks away, that's what I like to do the most. Watch what he's doing.
Right.
So, I'm a geek. I'm an engineer. And I understand feedback loop and control system, stability control. And so if you combine all those two and you see somebody the way they move, you can see what's holding him back. And then I use the diagnostic algorithm and figure out what tissue that is doing, and I fix it. They get up again, they're better, and they're faster.
And should you expect then that when you re-video it to see something different on the video?
Absolutely.
Yeah, okay.
Yeah, you definitely see it, re-video. But you can see it. You can fix that in 5 minutes. There's the change.
Right.
Mm-hmm. And it's a relatively permanent change.
Right. And I know you have like a very holistic global approach when you work with like a patient, and you don't necessarily always treat the site of complaint, of course. What are some of the things to like put some boundaries on that though? I mean, it can't just be, well, it can be anywhere.
Well, I'll start with working with a football team, for example. Mm-hmm. So the trainer will say, the ankle's hurt. So I'll try to fix the ankle and do what I can to fix the ankle. But in the back of my mind, I'm thinking, why did the ankle get hurt? Well, in football, they kind of bump into each other. So, it may not be anything biomechanical, like just because of the impact.
Right.
Hurt his ankle. But I'll check. And I'll check the strength and motion in the position that they're doing, that where they got hurt, or take a random one, a compound motion, and check. But if I have a lot of time, then I'll screen the entire person. The SFMA is a great way to do that. And that gives you starting points for lots of problems.
Sure.
Yeah.
Yeah, sure.
Yeah, I love it.
It's good. Well, we nailed it. We went way longer than we thought we were going to. It's usually how it works. So thank you for your time.
I talk a lot.
No, that's a good thing.
Perfect.
Got it. It was so informative. So I just got to give one more plug for the first weekend in November at Parker University in Dallas. It's going to be an amazing weekend. So the two of you talking on your respective disciplines, Antonio Stecco, Michael Shacklock, Jeffrey Bove, Bill Morgan, Annie O'Connor. It's going to be amazing. So stay tuned for registration links and stuff like that. The flyer is on our gestaltedu.com, on our Instagram and things like that. Stay tuned for the ART fascia course coming soon. So I can't wait to see.
I wish it was tomorrow. But
Aaron's wishing it was tomorrow too.
Yeah.
So that's right. So thank you, Aaron, for setting this up for us again. Guys, come out here and take a course in this beautiful area. If you're watching on the YouTube, we're washed out because I wanted to have the beautiful mountains in the background. So way out here in Colorado Springs. Thanks again, and good luck with patience.
Thanks for
guys.
coming by.
Yeah,
thanks, Mike.
It's always appreciate you.
Yep.
All right, guys. See you next time. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.